My name is Kenneth Abreo, and I'm Professor of Medicine at LSU Health Sciences Center in Shreveport. I have no disclosures. As you see in this slide, stenting can be done for atherosclerotic renal artery stenosis. In the left panel, you see a tight stenosis that's very close to the aorta in the proximal part of the renal artery. And in the panel on the right, you see the stenosis has cleared up with stenting. So the images are very excellent, and stenting is preferable for atherosclerotic renal artery stenosis because one is the success is high compared to just angioplasty, and the procedure is durable in that it is long lasting. So the question is stenting to be done in every patient who has atherosclerotic renal artery stenosis? How do we make the diagnosis? Which are the patients we need to investigate? Are there any risks for this procedure? Are there any risks for investigating patients? I hope that the following few slides will answer those questions. Let's first go to basics. The etiology of renal artery stenosis is primarily from two causes. The majority of patients, 85%, have atherosclerotic disease, and they are usually seen in men in their older years or greater than 45 years. The lesions are ostial and in the proximal part of the renal artery. A smaller percentage is fibromuscular dysplasias that's seen in women in the third decade, and it involves more the distal part of the renal artery. Actually, in both atherosclerosis and fibromuscular dysplasia, other arterial beds are involved. For example, in women, carotid and femoral, but you can also see carotid involvement in atherosclerosis. Rarely, stenosis could result from the placement of an aortic stent graft or from dissection of the aorta and so on. Now, the consequences of renal artery stenosis, in brief, there is release of renin, which activates the renin-angiotensin system, and angiotensin II then has many adverse vascular effects. There's sodium retention, there's aldosterone secretion, there's an effect on the vasculature and on the myocardium. There is a difference in the pathophysiology of renal artery stenosis, whether it's unilateral or bilateral. On the left panel, you can see unilateral renal artery stenosis. On the kidney that has undergone the stenosis, there's an increase in renin and aldosterone. However, the other normal kidney compensates and tries to lower the renin and aldo and dumps salt in the urine. The result is a high renin and high aldo, hypertension, but no retention of salt, and so less chance of developing heart failure, volume overload. On the other hand, in bilateral renal artery stenosis shown on the right panel, which can be seen in both renal arteries or in a single kidney stenosis, like in a kidney transplant patient, you see salt retention. Renin and aldo initially go up, but as you retain salt and the volume increases, the renin and aldosterone are suppressed, and these are the patients who develop volume overload and flash pulmonary edema. If the stenosis becomes severe, as shown in this slide, when it advances beyond 70 to 80% stenosis, there's a significant fall in the renal blood flow, and that leads to cortical and medullary hypoxia, capillary rarefaction, interstitial inflammation and fibrosis, and the kidney basically becomes really small and shrunken. And at this point, even correcting the stenosis will not bring back kidney function. And this is an important point when you are deciding on therapy. Now, what are the clinical features that suggest renal artery stenosis? Any patient who has resistant hypertension, which is defined as a patient who is taking 3 blood pressure medicines, one of which is a diuretic, and you have gone up to the maximum tolerated dose. Unexplained acute kidney injury or acute kidney injury after administration of an ACE inhibitor or angiotensin receptor blocker. The presence of diffuse atherosclerosis, a unilateral small kidney, or asymmetry in the size of the kidney by more of the one kidney to the other more than 1.5 centimeter. Patients with recurrent episodes of flash pulmonary edema, abrupt onset of hypertension, if the person is younger than 30 years of age or greater than 55 years of age. And finally, the presence of a systolic or diastolic abdominal bruit, which is heard rarely, so it's not a very sensitive, but if it's present, it's very specific. This slide pretty much shows you that when you have atherosclerotic renovascular disease, you have involvement of other arterial beds. The red bars show patients with renal artery stenosis, the blue without renal artery stenosis. And you will notice that the patients with renal artery stenosis also have coronary artery disease, peripheral vascular disease, congestive heart failure, strokes, and a higher incidence of death and chronic kidney disease. So the first question that we have to answer is, when we are making a decision to embark on diagnosis and treatment, are we going to investigate which patients are we going to investigate? Randomized controlled trials show that blood pressure is controlled in most patients with renal artery stenosis. And here are several landmark trials. The more recent ones was called STAR, showed no difference between stenting versus medical therapy at 24 months. Then came Astral, which progresses from the STAR. Again, no difference in kidney outcomes, blood pressure, cardiovascular events at 34 months. And finally, the CORAL trial in 2014 showed no difference in primary composite outcome, including kidney outcomes, cardiovascular events, and death at 43 months of follow-up, showing that medical therapy is equivalent to stenting intervention. And that made the American Heart Association in 2017 to recommend medical management as a primary treatment for renal artery stenosis. The second point is that there is no routine blood or radiologic tests that will consistently predict who will benefit from revascularization. You have to remember that testing is associated with potential risks, especially in patients who have impaired renal function. Patients may get contrast nephropathy from contrast media. They may develop nephrogenic systemic fibrosis if they are given gadolinium for an MRI. And they may develop thromboembolism when doing a conventional arteriography. So testing is only indicated if you feel that a corrective procedure would be performed if you detect clinically significant renal artery stenosis. So, which is the best diagnostic test? The choice will depend on local availability, what's available in your hospital, the clinical expertise of the radiologist in interpreting each technique, and the presence or absence of kidney failure. Patients without renal insufficiency, you can start with a duplex Doppler and progress to either CT angiography or MR, magnetic resonance angiography, And then finally, intra-arterial angiography is the best and most specific test. Patients with renal insufficiency, as I said, you have to be cautious. Duplex Doppler would be the best test because it avoids contrast and gadolinium exposure. Spiral CT with CT angiography in patients with low, poor kidney function. You would have to give IV normal saline, hydrate the patient, and avoid magnetic resonance angiography as far as possible because of the danger of gadolinium toxicity. So here are the diagnostic tests for renal artery stenosis. Doppler, you look at the peak systolic velocity, PSV, of the renal artery. If it's greater than 200 centimeters per second, then you have a very high sensitivity and specificity that you have a stenosis. However, this test is very operator dependent and also depends on the patient's body habitus. In obese patients, it's very difficult to do a good Doppler study. Another thing that they do is they'll give you a resistive index. If the resistive index is more than 80 or 0.8 in some testing places, then the kidney has irreversible kidney damage and will not benefit from revascularization. Spiral CT is the highly recommended test, has a very high sensitivity and specificity, mainly for atherosclerotic disease. It's less useful in fibromuscular renal artery stenosis because the lesions are distal and more within the kidney. The same holds for magnetic resonance angiography. It has a good sensitivity and specificity for atherosclerotic renal artery stenosis, but less so for fibromuscular renal artery stenosis. The gold standard test, of course, is renal arteriography, both for atherosclerotic and fibromuscular renal artery stenosis. There are other tests of limited utility, like plasma renin activity, which may or may not be increased. Captopril renogram, which is better to be used to find out whether the patient has significant renal function, and the renal vein renin, which has many false negative and occasional false positive results. Another question you ask yourself is, will restoring the renal blood flow benefit kidney function? And there are some clues that will tell you whether kidney function will recover. First, I told you was a resistive index. If the index is less than 0.8 or less than 80, then suggestive of renal recovery. The 6-month trajectory of renal function. If there has been recent deterioration of renal function, that suggests that there's possibility for recovery. The size of the kidney, if it's less than 7 centimeters, less likely to recover. Kidney biopsy, of course, will tell you whether there's interstitial fibrosis in the kidney, and it'll tell you whether the patient is going to recover or not. And finally, you can do MRI for morphology to see if the structure is good, and you can do a radionuclide scanning to look for function. Combine the two tests and see whether there is room for recovery, whether the kidney is a hibernating kidney that will recover. And finally, the decision to embark on diagnosis and treatment. The procedures themselves have morbidity and mortality, the procedure of angioplasty and stent placement. And therefore, if your patient's blood pressure is well controlled, kidney function is stable, you are less likely to go into diagnostic and therapy of this condition. Here are some of the complications of the more recent trials. In the STAR, a randomized control trial, there were 2 patient deaths. In Astral, there were also 2 patients' deaths. And in Coral, they had several complications, including 11 patients with arterial dissection. So the the diagnostic procedures and the therapeutic procedures have their own risks. You have to take that into account. Let us now, using the information that we have gathered, use it to decide on a couple of cases. So the case one is to stent or not to stent, as Shakespeare said, to be or not to be. Here is a patient who on Doppler had very high peak systolic velocities. In this case, 355, and I said the cutoff was 200. And on spiral CT, you can see on the right side, there's a very tight stenosis, maybe 80% or so. When you look at the clinical picture, however, the patient is on 3 blood pressure medicines. Blood pressure is really well controlled, and the creatinine is stable at 1.1. So the question is, will you stent this patient or not? And the correct answer is no. You're not going to stent this patient because the patient is doing really well, and you may actually do some harm. You will follow this patient. If the kidney function deteriorates, if the blood pressure becomes uncontrollable, at that point you may go for testing and therapy. Now here is another case, to stent or not to stent. The first point in this case is that the patient is on 5 blood pressure medicines to control the blood pressure. The second is the blue bar represents the serum creatinine. And you will notice in the past 3 years, there's a steadily increase in the serum creatinine. The third point is there was an episode of acute kidney injury, and they had to stop giving the valsartan, which is an angiotensin receptor blocker. Then the fourth point is patient had repeated episodes of flash pulmonary edema. Now, when this patient was tested, the right kidney was completely shrunken, and the left, where you see that yellow arrow, had a very tight stenosis. On Doppler, you can see that there's pretty good renal parenchyma on ultrasound, but the peak systolic velocity is 555, way above the cutoff of 200. So this patient then underwent stenting, as shown here, renal artery stenting. And the answer, of course, here is to stent. And following stenting, renal function improved significantly, and the blood pressure was better controlled on 3 blood pressure medicines. So this is the kind of patient you would stent. Now, what's the treatment of fibromuscular dysplasia? And these are young people who have hypertension, and the fibromuscular dysplasia affects the distal renal artery and the branches. And the similar approach would be used if the blood pressure is very difficult to control, if renal function is deteriorating, then those are the patients that you would have to treat. And the treatment of fibromuscular dysplasia is angioplasty. It's much preferable to do angioplasty than place the stent. Here's an example on the left. You can see the beaded appearance of the distal renal artery. And then on the right panel, B, you can see postplasty. The patient had improvement in kidney function and easier to control blood pressure. So my key points to this question of what is the role of stenting for renal artery stenosis. Majority of your patients with atherosclerotic renal artery stenosis do not need stenting if their blood pressure is controlled and their renal function is stable. Patients with atherosclerotic renal artery stenosis need stenting if you have resistant hypertension, deteriorating renal function, episodes of flash pulmonary edema. Prior to placing a stent, make sure that the kidney is viable and you may have to then do Doppler ultrasound, MRI, and radionuclide imaging. And to keep in mind that the tests such as CT scan, CT angiogram, which is the best test, and the gold standard test, renal arteriogram, that they have their own, problems. But if your patient needs it, you have to embark on these tests and embark on this treatment. I think that's the end of my presentation. Thank you for being a wonderful audience.